focal infarction and occlusion. So it's not very easy.
I wanted to ask, is it important now for us to detect every aneurysm, since we are not, treatment methods are different, we are not really targeting? So that's what comes to my mind.
Can I take that, please? So I'd like to say that the concept of the question of Octa replacing FFA is a moot point there. Every day we are learning new things about Octa and looking at DM in a totally different way, not just seeing the size of the FAZ. The FAZ itself, there's a big controversy as to whether you have to look at the FAZ as a whole slab, whether you look only at the SVP FAZ, the DVP FAZ. So what does this mean? That it means that every day we are finding new ways to look at a particular problem. The current issue is that we have not enough data to substantiate what is important and what is not important. But that only time will give us. When we started with the OCT, we just measured the central retinal thickness and that was it. Now we look at the type of edema, we look at particles suspended, we look at all these things. So give it another 5 years and OCTA is going to be a different investigative modality in DME. It is the question of replacement of FFA is not there. And another point to that is that we cannot separate OCTA from OCT. You cannot interpret an OCTA image unless you have the OCT right by its side. There are protocols like the Humphrey field analysis, which now the reporting system is going to be like you have to have the corresponding OCT, the corresponding on-fast image, and the corresponding OCT image to really interpret what is happening in an Octa image.
Well, I invite Unni to start off his presentation. One last question, Santosh. Like how we have quantification methods for OCT, do you have anything where we can, map out which are part of the algorithms to quantify? We continue to monitor the ischemic area, right? Through the algorithms itself. How do you quantify the ischemic area is what I'm saying.
Yeah, you can, but again, you need to kind of change the segmentation and then see.
Manually.
Yeah, that's other problem. You can't really go by
the
most of the studies, they have taken their default segmentation, but if you kind of change, everything changes. Okay. So if you look at the limitations in all these papers, they say that. So the limitations again is the fluid that is there. If it's a flat macula, nothing like it. But if it's not a flat macula, it's not easy.
True. Thank you so much.
Thank you.
Over to you, Unni.
So good morning, everybody. Thank you, Dr. Chaitra, for the invitation. So I'm just going to a very, not a routine topic, an interesting topic, but slightly slower than the Octa. So this topic you can also consider as this. What are the treatment options for anti-VEGF resistant DMEs? So it's the same thing. When do you switch? So this is something that is written in one of the studies, that 20% of diabetic retinopathies do not respond fully to anti-VEGF treatment. But I would go to say that in our practices, we're looking at nearly 60 to 70% probably. And we'll just go to the reasons that why we say that they don't respond properly. It's not one answered questions. I have 10 unanswered questions over here, starting from what do you really call a poor response? What do you mean by a suboptimal response? Are there differences in the CME or DME that don't allow them to think? Is there a real difference between the anti-VEGF agents? What do you really mean by treat and extend in DME? So we'll go through all these. What are the characteristics and the biomarkers for switching? We'll just go through some of these questions. Okay, so before we define anything, we know we have to, for the sake of this discussion, what was considered to be standard treatment? Standard treatment was considered as 4 injections, then a 5th injection and a 6th injection over a period of 6 weeks, and laser at 24 weeks if it didn't work. Okay, this was the studies. Okay, we have to keep this aside, but we just have to know what was meant by standard. And this was how treatment was managed. That when you give anti-VEGF after the loading dose, if it improves, you keep on giving. If it doesn't improve or it's the same, you do not. If it worsens, you keep on giving. So that means if it is improving, you keep on giving. If it's worsening, you keep on giving. But if it is static, you have an option of, this is what the study protocols defined. And what was meant by success? Okay, we have success in treating DME was called anything less than 6/6 vision as a vision criteria and less than 250 microns. If you're using a Heidelberg, this 250 is 320 microns because the estimation of DME is, the values are different. An improvement is when it improved by at least 10%. No improvement was called it didn't increase by 10%. There are 2 terms called futility and failure also. futility is checked after 52 weeks. So essentially, these are the definitions by the DRCI network. But we are more focally concentrating on two definitions. What do you mean by persistent DME? Persistent DME was tagged with a figure of 6 months. And then you had the OCT criteria of 250 microns. Then you had chronic persistent DME, which was 6 months plus 2 visits. That is, you take it up to 8 to 9 months. So these are the definitions that are around when you're dealing with DME. So that was the point of defining what do you mean by standard treatment. Now let's define poor response, okay? So essentially, if you look at the figures, roughly 70% of people have either a poor visual response or a poor OCT response. That's a really important fact to know, that a patient coming to you with DME, 7 out of 10 chances he'll still have DME after you try your best with him. So when do you consider anti-VEGF response? Again, the two values are less than a 25% decrease from the original. We're not talking about 10% here. And we're considering about if the value does not come between 225 to 300 microns, you consider it as anti-VEGF resistance. But the funny thing is that for the point of switching, there is no definition of, none of the studies have mentioned a definition per se. What do you call it as DME for the point of switching? So we are just dealing with monotherapy definitions here. Why do you call it chronic? When do you call it chronic resistant? When do you call it persistent? This is something to keep in mind throughout the whole presentation. Second question, is it really a suboptimal response? So before you label a person as being anti-VEGF resistant or not responding, the most important thing is to check two things. Has the fluid gone away and has it come back? Then it is not persistence. The second point, is the visual acuity maintaining or is it improving? That's also important. And the third point is that, we'll come to the third point later. I'm just keeping it as a little bit of stuff. But these 2 points, you have to really know whether you're going to call it a persistent DME. So, and this is the point I'd like to make. Underdosing with anti-VEGF is the most common reason for calling it a suboptimal response. We convince ourselves that you're treating the patient properly. The patient says, okay, next injection 4 weeks, or my domestic help was not there at that time, so I came 2 weeks later. You're underdosing him by no fault of yours and no fault of his or hers, but still you're underdosing him. The injection is 2 weeks late. So let's look at some other things that are not under your control. The persistence of edema could be independent of VEGF. Okay, there are lots more other VEGF factors which you're not suppressing. Let us not presume that all DME is because of VEGF. There's platelet-derived growth factors, there's placental growth factors, there's a whole gamut of markers over there which we're not looking at. And the fun point is that the more VEGF you get, the more of the other factors are going to be enhanced by blockade. So this is also a reason why DME does not respond to VEGF sometimes. Now, the whole fun about switching, I would say, is in your mind more than the patient's mind. When you say, this is not working, I'm going to switch you, you're excited about it. Every compliance patient issue the patient had with VEGF, anti-VEGF A, is still there with anti-VEGF B. So unless you note and treat or take care of that particular thing, why he hasn't got an injection at 4 weeks? Why is he getting at 8 weeks? You switch from A to B, the patient is the same, the compliance issues are the same, the patient's domestic help is the same, the lack of the driver is the same, all those things don't change. So you have to address compliance issues before you change the anti-VEGF. In a real life scenario, let's look at suboptimal treatment and suboptimal response. In a real life scenario, if you don't get any response after 2 injections, that's the time to pretty much think that you have to think that something may not be right. You could even look at, I would say 3 rather than 2, sorry there. And you're looking at a 20% reduction. So I put this in 3s, 3 reasons for treatment failure, okay? And what do you mean by customization? For me, there are 3 types of customization. One, you give the patient a treatment holiday. Why it is important, we'll tell you. Second is a switch. That is the main point of this topic. And the third is adding other modalities. So there are 3 mechanisms of VEGF. That is permeability, inflammatory, and leukostasis. I'm not going to that. But essentially, the 2 mechanisms say that one is VEGF mediated, one is VEGF plus inflammatory mediated. And that is why VEGF does not work all the time. Suboptimal response. As you said, there are inflammatory pathways along with VEGF